This week on the Galactosemia podcast, we've got an episode that's a bit different. This week we're looking back on the Voice of the Patient report. You know, I was reminded of the Voice of the Patient report this past week when we took Elliot to a neurology appointment to get checked out for testing for some seizures. When the pediatric neurologist came in, he said something that, we hear a lot in the community, which is that he hadn't heard of galactosemia before and he wasn't familiar with it. But he did say that he had read up on it and that he had read the Voice of the Patient report, which was actually very comforting to hear. And it occurred to me now that we have this report that could be a likely scenario and a regular occurrence where someone goes to a doctor's appointment and the doctor is not familiar with CG beforehand, but they read up on it by reviewing the Voice of the Patient report. So I wanted to do an episode that focuses solely on that report and the meeting that it was born from. The background on this meeting is that in September of 2022, the Galactosemia Foundation hosted a 4-hour meeting for the FDA. It's called a Patient-Focused Drug Development Meeting, and it's a super important meeting because it's the one chance that the community gets to tell the FDA why galactosemia is important, what the effects are, what the treatment looks like or doesn't look like, and what our needs are. This meeting then got put into a report, which is called the Voice of the Patient report, which is available publicly, and anytime that a drug comes before the FDA, they pull this report to review the needs of those with galactosemia. The report has a clinical overview of galactosemia, stories of people living with galactosemia, perspectives on treatments, and a lot more. In my experience, it's also a really great resource for doctors and medical professionals that aren't familiar with the disease, but they come across it in a case and they're able to read up on it. So in today's episode, I've taken that 4-hour meeting and I polished up the audio and trimmed it down to about an hour and a half and posted it for the episode. There's obviously a lot more from this meeting than is in this episode, and if you want to watch or listen to the full thing, it's available on raredisease.org. I've also posted the full 4-hour video on the galactosemiapodcast.com. As always, you can sign up there to get these episodes ad-free and support this project. Okay, before we dive in, one last thing. I heard this recently. Dr. Barry is actually stepping down. Now, you know Dr. Barry. He's obviously one of the biggest researchers and really a champion of research in the field of galactosemia. Without his efforts, I truly believe that we would be decades behind where we are now with what we know about CG. He was on episode 3 of this podcast, so if you haven't heard from him, go check out that episode. Boston's Children's Hospital Division of Genetics and Genomics is hosting a symposium for Dr. Barry this Friday. I'm going to try and see if we can get a recording of some of those speakers and post some of that stuff in a future episode. But I think it's a great time to reach out to Dr. Barry and say thank you for everything that he's done as he reaches the end of his time at Boston Children's Hospital. So a big thank you to Dr. Barry, and feel free to reach out to him yourself. Okay. Now to the episode in the trimmed down galactosemia patient-focused drug development meeting. Enjoy.
Good morning, everybody. My name is Debbie Drell, and I'm the Director of Membership at the National Organization for Rare Disorders, or NORD. I'm your co-host for this patient-focused drug development meeting. I'd love to introduce my friend and yours, Scott Saylor, who is also our co-host for this meeting. He's the treasurer of the Galactosemia Foundation. Scott.
Hi, Debbie. It's good to be here and to welcome everyone participating and watching this live on their computers and phones. We are being broadcast live from Washington, D.C., not too far from the U.S. Food and Drug Administration's headquarters in White Oak, Maryland.
So this meeting, what is it? It's a patient-focused drug development meeting. What does that actually mean? If you're in this meeting, it may be the first time you're hearing of these words. It's a more systematic way of gathering the patient perspectives on your condition and on available treatments. Your input can help inform the FDA and other drug developers in their understanding of galactosemia, and especially with the FDA when they're being informed of drug development and review.
Good morning. My name is Nicole Casal, and I am the president of the Galactosemia Foundation and have a son, Joseph, who was diagnosed with classic galactosemia in 2012. Today, he is 10 years old, and he is my inspiration for being involved as a volunteer in this community, as well as the Galactosemia Foundation for the past 8 years. Before we delve into this meeting, I wanted to give a little bit of information about the Galactosemia Foundation. Back in 1985, during a time when there was no internet, limited emails, no texting, primarily just phone calls and letter writing. And more importantly, when galactosemia wasn't part of the National Newborn Screening Panel, a group of mothers came together to form the nonprofit known as the Parents of Galactosemic Children. Today, we are known as the Galactosemia Foundation, and we look a little different as connecting with others and advocating for those affected by galactosemia has changed so much. But our mission has always been the same. We strive to support, connect, provide education, and provide advocacy for those affected by galactosemia, as well as to network with professionals to inspire the treatment and research of galactosemia. Now, we know that hearing from families with galactosemia is critical to their efforts. So I would like to thank the U.S. Food and Drug Administration for allowing us to hold this meeting and for attending today. We know that they are amazing individuals that overcome so much, but it's time for the unmet needs that they have to be met. Now, we hear the term unmet need a lot. This is a term that is often used by researchers, health professionals, policymakers, biopharmaceutical companies. The FDA defines unmet medical need in part as a condition whose treatment or diagnosis is not addressed adequately by available therapy. It strikes me that galactosemia is all about unmet needs, as every symptom needs addressing, and as it stands, there is no current treatment and there is no cure. Now, to the families and individuals with galactosemia participating today, this meeting is a unique opportunity, one where the day is dedicated to having our voices heard.
Next, we'll have a clinical overview provided by Dr. Judy Fridovich-Keil.
Hi, my name is Judy Fridovich-Keil, and it's my privilege to tell you a little bit about the clinical overview of galactosemia. So the central enzymes of galactose metabolism make up what is called the Loire pathway. And there are other enzymes that also impact this pathway and the metabolism of galactose. So galactose can really enter the human, or really any other species, from two different ways, either from environmental sources, which is typically dietary sources of galactose, and milk is the predominant source of galactose in the human diet, or we can make galactose endogenously. And we have an enzyme called epimerase, which allows us to make it. And I just want to point out that if we couldn't make it, we wouldn't be here. Being able to produce galactose endogenously is actually essential to life. So that's very important. So you will see that there are a number of different enzymes here. We're going to spend most of our time in this session talking about galactose 1-phosphate uridyl transferase, which is abbreviated GALT. But you'll see that there's also a galactic kinase, which comes before it in the pathway, and epimerase, which comes after it in the pathway. There are other enzymes that don't normally work on galactose unless it builds up to high levels. But in patients with galactosemia, drinking milk, it can build up to high levels. And then an enzyme called aldose reductase can turn it into galactitol. Galactose dehydrogenase can turn it into galactonate. So there are a number of metabolites that you will hear a little bit more about. So again, I just want to stress that galactose can come in from the diet, but it also is produced endogenously. And even if we put an individual on a completely galactose-restricted diet, as we will talk about in a minute, for patients with classic galactosemia, their bodies are still synthesizing galactose, and that is something that happens lifelong. So what is galactosemia? It's really a family of conditions. So first, classic galactosemia, which is most of what we're going to be talking about now, and I'll abbreviate it CG. This is an autosomal recessive condition. So that means in order to have an affected child, you need two carrier parents. How is classic galactosemia detected and diagnosed? In the US, since 2004, essentially all babies have been screened for classic galactosemia by newborn screening. So this is a program that began in the early 1960s. And although all states do newborn screening, exactly how they do it and which conditions are on their panel is statewide, is a state decision. Diagnosis really requires a follow-up, much more rigorous approach to doing the GALT assay on a fresh blood sample, not a dry blood spot. And this is often combined also with careful Gal-1P testing, so not T-Gal, but actual Gal-1P, and sometimes also GALT mutation testing. And in most states, the algorithm that they use is designed to minimize false negatives. You never want to miss a kid with classic galactosemia. And what that means is that they err on the side of having more false positives. So there are many children, many infants who have an out of range newborn screening result for galactosemia, which does not ultimately lead to a diagnosis of galactosemia. There are many false positives. Okay, prevalence of classic galactosemia among screened U.S. newborns. These are data from a study we did we published it in 2014. And you can see these are the different states that shared information with us, the number of years of data that we were able to get. And what you can see is that the prevalence, again, it bounces around. This is statistics of small numbers, but the prevalence is about 1 in 50,000 screened births. So the question is often asked about how many people in the United States currently live with classic galactosemia. And again, this graph shows how different newborn screening programs added galactosemia to their panel. So 2004 is the magic year when we hit all of them. So there are actually 51 programs because DC has one. So best estimate is about 3,000 people currently live in the United States with classic galactosemia. So this is indeed a rare condition. So one might ask, why is this less than 1 in 50,000 times the current U.S. population? And again, it's because babies born in states before newborn screening for galactosemia typically did not make it. So the population of people with classic galactosemia is still really skewed towards young people, and it will be some decades before we reach equilibrium. Typically, from newborn screening data, it looks like maybe about 80 children are born each year with classic galactosemia who are diagnosed by newborn screening. What are some of the biochemical markers that are typically followed in clinical samples? And red blood cell Gal-1P is probably the most commonly followed, and galactitol, which can be found either in plasma, serum, or urine, is also followed. These are galactose 1-phosphate or Gal-1P values from patients with many different forms of galactosemia. And here, GG, these are the classics, and you can see that they have much more Gal-1P than their counterparts with other combinations of GALT alleles. So what is the clinical experience of newborns with classic galactosemia? It completely depends on whether you get them off of milk. So they're typically born looking pretty much healthy and happy. Sometimes there's a little bit of jaundice, but typically they look fine. The problem starts when they are exposed to milk, and this can be breast milk. So human breast milk has about 19% of calories from galactose, and cow's milk has about 15% of calories from galactose. That's a lot of galactose. It's in the form of lactose. And if the baby continues to either breastfeed or drink a dairy milk formula, they will, within days, begin to experience really a rapid progression of just heartbreaking and potentially lethal conditions. And this is what happened to most babies with galactosemia before newborn screening. Good news is that with the benefit of early newborn screening, you can immediately switch them off of milk and onto a low galactose formula, which is typically a soy-based formula, but there are also other options. And you get back an apparently healthy infant or toddler. The problem is that despite early detection and early and lifelong intervention, so despite dietary restriction of galactose, most, but not all, patients with classic galactosemia grow up to experience a whole constellation of long-term complications. And these are data from a European study, but we've also studied a lot of patients from the US, and we see similar kinds of numbers. Most have some kind of cognitive difficulties. Speech and language are also a challenge for many patients. Neurological problems, these can be motor or seizure problems. Socio-emotional problems are also very common. This is often involves anxiety or depression. And then there are others. Low bone mineral density is a problem For girls and women, primary ovarian insufficiency is extremely common. Switching the baby off of milk and onto a low galactose formula is life-saving, and I don't want to in any way diminish how important that is. That is amazingly important, but it doesn't solve the problem. So really, there are two take-home messages. The first one is there are a lot of challenges that many of these children experience, and for many of them, they last into adulthood. So these are not problems that go away as you grow up. They're problems that you keep, that for many people are really lifelong challenges. But I also want to just make it very clear that there is a big range, and that range overlaps with the control range. So not every patient with classic galactosemia has the same long-term outcome. Some do really well. Some struggle in every category, and most are somewhere in between. So what are the treatment options? Immediate and continued dietary restriction of galactose. That's front and center. That is absolutely life-saving for infants, but it fails to prevent the long-term complications as the child grows and in the adult. So we need something more. And I also just want to point out that speech therapy and other special educational services make a difference. They make a huge difference. Again, they don't solve the problem, but they can absolutely improve outcomes. And so I want to give a shout out to those. But there is no question that a more effective treatment is really needed to prevent or minimize the long-term complications of classic galactosemia. So summary. First, classic galactosemia is an autosomal recessive disorder that impacts about 3,000 people currently living in the United States and about 1 in 50,000 of all newborns born each year in the US. And classic galactosemia results from profound deficiency of the GALT enzyme. If a baby with classic galactosemia continues to drink either breast milk or dairy milk formula, they will become acutely ill and they could die from that. Essentially, all infants with classic galactosemia born in the United States are now detected by newborn screening, and this enables rapid dietary restriction of galactose. Again, that is life-saving. However, despite this standard of care intervention, most older children and adults with classic galactosemia nonetheless experience a constellation of long-term developmental and other complications, and this is a problem. The pathophysiology of most long-term complications in classic galactosemia is really not well understood, including which metabolite is causal. So that has been a challenge. And improved treatment to prevent or minimize long-term complications is dearly needed. Thank you.
Good morning. I'm Dr. Sheila Farrah, a pediatrician in the Division of Rare Diseases and Medical Genetics at the Food and Drug Administration. I would like to start by sharing a little bit about what we do at the FDA. The FDA is responsible for protecting the public health by ensuring the safety, efficacy, and security of human and veterinary drugs, biologic products, and medical devices, and by ensuring the safety of our nation's food supply, cosmetics, and products that emit radiation. Now we move on to why patient-focused drug development meetings are so important. Patient perspective plays a key role from the very beginning of the life cycle of a drug. We recognize that patients are the experts and have the information that all stakeholders need to know about what symptoms and burdens matter most to patients, and also what risks patients are willing to accept for a certain level of benefit. The information we learn today from patients can help investigators and sponsors to design better clinical trials by focusing on demonstrating that the drug has an effect on an outcome measure that patients report are clinically meaningful to them. The information we obtain at this meeting is critical and will strengthen our understanding of galactosemia and how it impacts patients. This input will help all stakeholders in their respective roles in the drug development and evaluation process. The great news is that the information you provide today will not only help those of us present at the meeting, but since it will be compiled into a report, it can inform all stakeholders well into the future. After the meeting, once compiled, the report from this meeting will be posted on the website listed here under externally led patient-focused drug development meetings. Additionally, there are 2 other websites listed that patients and stakeholders may find helpful.
A big thank you to Dr. Farrah from the Division of Rare Disease and Medical Genetics at the FDA for being here and providing those welcome remarks from a regulatory perspective. We're also appreciative of Dr. Judy's informative talk to lay the foundation for our dialogue with the community. Dr. Judy is one of our research and medical advocates who supports greater understanding of galactosemia.
Now we're going to get to the best part of today's meeting, which is to hear from you directly, patients and caregivers living with galactosemia, because who better knows this disease than those living with the disease? The patient and caregiver testimonials are really at the core of this meeting.
The FDA is watching now live, and they've told us that these meetings bring a depth of understanding that their scientists, regulators, and staff find helpful in their work. No one knows this better than those living with the disease and those who care for them. We're going to shine a light on these stories. Let's start. We have asked a panel of caregivers and patients to share the way galactosemia came into their lives, describe the symptoms of the disease, and how it profoundly changes entire families and their lives. Earlier this year, NORD and the Galactosemia Foundation made a call for stories, and we received dozens of patients and family submissions, and they were incredible. We selected the individuals for this panel to try to capture the most diverse experiences living with galactosemia. But this is just the beginning. So without further ado, I want to turn it over to our first panelists.
My name is Jillian Sapia. I am from Lake Worth, Florida. I am a mother and a registered nurse. As an RN, I have seen everything, probably every body part inside and out. I've been trained in critical care and critical thinking. Nothing prepared me for rare disease and my daughter's diagnosis of galactosemia. Penelope was born August 3rd, 2017, and she was perfect. A few days after getting home, we received this voicemail. Your daughter tested positive for classic galactosemia. It's probably a false positive. Nothing urgent, but come in and follow up. At our follow-up, the doctor checked her out and gave us a poor explanation of galactosemia. Penelope had signs and symptoms at that visit that something was wrong, but my nursing intuition wasn't kicking in. My motherly instinct was just to follow what the doctor said. Unfortunately, an hour after getting home from that doctor's visit, I was holding her limp and almost lifeless in my arms. Penelope was hospitalized with metabolic crisis, liver failure, and hypoglycemia. A little crash cart rested outside her room in case of cardiac or respiratory arrest. I was completely engorged, leaking breast milk all over myself for days, post-C-section and in tons of pain. I held her thinking it would be my last hug, my last kiss, my last everything. The lactation consultant would come in and ask me how breastfeeding was going. I would be asked at every appointment for the next 2 years if I was breastfeeding. Breastfeeding culture is difficult when you have a child with galactosemia. Socially, they want you to do one thing, but what's best is totally different. The first year, I was terrified of everything. I questioned everything I did. When introducing food, Penelope had bloody stools for a month. Her doctor thought she had an immune gut from possible E. coli GI sepsis during the newborn screening or the newborn stages. Then, at 2 years old, I noticed absent seizures. Again, I questioned myself as a nurse, is this what I'm seeing? But unmedicated, she has seizures every hour in clusters. I was told she's now at risk for status epilepticus, a seizure that never stops and that she could die from. I carry a rescue med everywhere I go. I also carry the weight of her dying in her sleep. Seizures complicate everything. A simple ear infection and stress from her sensory processing disorder can trigger more seizures. Coordination of care is super frustrating. I have to call in any changes to each specialist to make sure one order doesn't affect the other. There are whole days of traveling for EEG at the hospital and labs. When she knows this is going to happen and we're going to the hospital, we can't make it without her throwing up from the stress. This has caused great emotional stress for me, watching her go through all of this. Penelope has had a long history of painful chronic constipation, nausea, vomiting, hypotonia, speech delays, developmental delays, sensory processing disorder, and even dental issues from undeveloped baby teeth. Caring for Penelope and all the accompanying issues from galactosemia has been complicated by my also dealing with depression and PTSD that developed while caring for Penelope. August 2022, we were scheduled for our first drug trial. However, COVID hit and everything stopped. The week we were supposed to go, she got very sick and stopped walking. A stat MRI showed a significant Chiari malformation. We know what it feels like when there's no treatment. Chiari at least had a solution, research, and experienced neurosurgeons. Penelope's brain surgery was difficult and included a medication error. She was given lactulose for constipation, which is literally milk sugar. The doctor, the nurse, the pharmacist, the computer system, her medical alert band, and the signs in her room could not prevent this error, nor any in the future. I spoke up, but the nurse blew me off and said the computer system would have picked it up. Unfortunately, electronic medical records need to be updated and reflect our current needs. There's not one EMR that reflects our metabolic allergies correctly. As Penelope grew, I learned more about her struggles. One week she could talk, then the next day she's babbling and reverting to toddler baby-like behavior. She has significant hand tremors. As a nurse, I swear I could smell high galactose on her just like a diabetic in ketosis. Her urine smells sweet. Her own body makes galactose, so even with a restricted diet, she will have challenging days. I wish I had a glucometer, just like diabetic would, but for galactosemia and milk sugars. Penelope is currently 5 years old. She loves to dance, loves vegan pizza and vegan ice cream. She is currently in an ongoing clinical trial for a new treatment. Our hopes for her in the future is that she can be empowered to do anything she wants. I want her to have all the opportunities any other child has with less medical worries and more options for help. Thank you so much for your time, and I hope I gave a good explanation of galactosemia.
Hello, my name is Elaine Olson. I believe I am the mother of one of the oldest living galactosemia patients. I have lost 2 other children from this disease. My son Jerry is now 61 years old. He is the 4th of my 6 biological children. My 2nd and my 3rd children were both girls who appeared to be healthy at birth, but both passed away undiagnosed at 1.5 months of age each. When Jerry was born, something didn't feel right, and I told my doctors that I felt Jerry had the same thing as the girls. The doctor told me I was a nervous mother and sent us home. I chose to breastfeed. In only a few days, Jerry became yellowish color, had significant weight loss. They continued to tell me that everything was fine. On day 4, history started repeating itself when I couldn't rouse him. We were young, frightened parents, once again rushing back to the University of Minnesota hospital that had treated our 2 other babies. Just like before, the specialist didn't know what was wrong with Jerry, but thought that the 2 girls and Jerry were somehow connected. But how? At this point, Jerry was in a coma with yellow skin and high bilirubin count, being fed through an IV. But like his sisters, he wasn't getting any better. The doctors eventually thought they had figured out what was wrong with Jerry. They started treating him even though the test results wouldn't come back for more than an entire month. When Jerry started to come out of the coma, we knew the treatments were working even before we received the official diagnosis that something we had never heard of before. It was galactosemia. From then on, Jerry was fed a meat-based formula. We were told he would need to stick to a dairy-free diet for the rest of his life. It sounded so easy for such a bad disease that took the life of 2 of his siblings. We were told that if we stayed in the prescribed diet, he would grow up to be a normal person. At first, the entire family was fed his restricted diet, but we decided that wasn't in Jerry's best interest. We needed to teach him what he could and could not eat when he was out into the world. His mother would not be at his side forever. If he didn't know about a food, our motto became, when in doubt, go without. We continued to be pioneers, facing this all alone, navigating his treatment in this new way of life. As he grew, his mental disabilities became more apparent. His younger brother, by 2 years, quickly passed him up in almost every aspect. We worried if Jerry's bones would grow properly without milk. I can report that he did grow to be 6'2". School was hard for Jerry. He was behind for his age in everything from reading to comprehension. He was taken out of the classroom for special education. He was bullied for what he didn't and couldn't answer in regular class. In Jerry's case, his disability wasn't physically apparent at all, so part of my job as his caretaker was to run interference with other adults, trying to explain his limitations before they put pressure on him to do something he could not do, like reading out loud. He had a hard time verbalizing what was bothering him and would become angry and frustrated when the stresses and anxiety became too much for him. We made the decision to move from the city to the country, thinking that would be a better environment for him, which it was. Jerry had never lived independently, cannot handle his own finances. He does have a driver's license and has been able to hold down repetitive jobs for most of his adult life. Most jobs were given to him from friends or family. Around age 55, Jerry started having visual seizures, which are now under control with medication. In hindsight, he may have been having small seizures all along. We noticed short moments of blanking out or disengagement, but he seemed to snap out of it when we'd call his name. Again, we are pioneers, just trying to figure everything out on our own. Change is hard for Jerry, but as his father and I aged, we felt it would be better for him to move in with his sister, who had taken on the responsibility of coordinating his care with the county and his medical professionals. At age 61, Jerry does receive partial disability, continues to work part-time. However, he is noticeably much more fatigued these days, and that's almost daily after the stress of working. My husband and I are both carriers of the gene that causes galactosemia. Of our 6 biological children, 3 were born with galactosemia, 2 are carriers, and 1 does not have it at all. Living with galactosemia has been quite a journey for our family, and we hope that sharing Jerry's story will help pave the way for those who come after him. Thank you.
Hi, my name is Cassidy. My daughter Elena was diagnosed with classic galactosemia on her 5th day of life. Before diagnosis, she had elevated bilirubin levels, projectile vomiting, and had diarrhea that gave her such an intense diaper rash, her skin would peel at the lightest touch. Once diagnosed and put on dairy-free formula, her acute symptoms faded. Elena's delays started early. She wasn't meeting for milestones, was crawling, standing, walking, and talking. Elena would get into a crawling position and then just stay there. Or, while standing, she would look so determined to take a step, yet some unknown force was holding her back. This led me to enroll her in early intervention. While working on her gross motor skills with an occupational therapist, early intervention identified a speech delay. Eventually, she was diagnosed with apraxia of speech. Her words were unintelligible. It was years of intensive work with a speech therapist to see any gains. I'd hoped this was the last effects of galactosemia. Unfortunately, in kindergarten, Elena was not learning like her peers. She had slow processing delays. It takes her longer to digest information and then respond. In school, this leaves her behind in her work. Socially, slow processing leaves her out of a conversation. By the time she's had time to process the information, people have already moved on. This frustrates her. She feels left out and in constant need to catch up. Despite having a strict diet, special education services since kindergarten, doing work after school, and hiring tutors, she's still about a grade level behind. As she reaches higher grades, I fear she will slip further away from her peers. What keeps me up the most about galactosemia is its degenerative nature. Although Elena has not experienced cognitive decline, tremors, and seizures, if it'll only be a matter of time. She has big dreams. She wants to be a veterinarian when she grows up. Sadly, she has mentioned her hesitation about being a vet, knowing just how much school they have to go through. I hate that galactosemia could rob her of her dreams. Her second dream is to be a mom. Most girls with galactosemia are infertile, caused by POF, premature ovarian failure. POF can cause osteopenia and osteoporosis. Treatment for this is hormone replacement therapy, birth control, indefinitely. It's heartbreaking. They also tend to be delayed in puberty, some only reaching puberty with medical intervention. Most people think of puberty as a dreadful time. We rejoice in it. Recently, Elena has shown signs that she's naturally maturing. You would think that this would be a great relief to me. But the truth is, about 80% of girls that naturally mature will then go into POF after only a few years. At any moment, her body could deteriorate. It feels like there's this huge cloud hanging over us, just waiting to take away any progress. Classic galactosemia has serious lifelong impacts. Thinking of the wide side effects of galactosemia, lifelong birth control, easy bone fractures, and academic delays is just devastating to me. Elena has to see many specialists just to make sure her body is functioning to the best of its ability. A geneticist specifically for galactosemia, a dietitian for nutrition, an endocrinologist to ensure her hormones are where they need to be, an ophthalmologist to keep an eye on cataracts, an orthopedist to ensure bone health, a GI doctor to keep her digestive tract healthy, a reproductive endocrinologist for reproductive health, a nephrologist to make sure her kidneys are okay, a pediatrician for other health-related issues, and a litany of diagnostic tests to watch for any bodily changes that are common with galactosemia. All of these doctor visits are costly. I've had to make unconventional decisions in my life in order to get Elena the care and therapy she needs. We are fortunate enough that my parents allow us to live with them. This takes some of the financial burden off of me, a single mom. It's allowed me to be there for Elena's therapies, doctor's appointments, and tutors. I had to put my career on hold and then completely change it in order to allow Elena a better quality of life. I'm in college now, but most people my age are well into their careers. These unique decisions I've made are solely the result of having a child with galactosemia. Despite all these unique sacrifices, I still have to figure out if I can even afford to see the reproductive endocrinologist who may be able to help Elena achieve one of her dreams. Elena has dealt with so much in her short life. Blood draws, eye exams, bone scans, restricted diets, extra supplements, poor growth, academic delays, slow processing speeds, speech and gross motor delays. She does it all with grace, kindness, and strength. I'm so proud of her. At the same time, I'm so mad she has to deal with all of this. There are times where I feel ill-equipped to deal with classic galactosemia. I realize it's because I am. There's no treatment for galactosemia, nothing that will abate her symptoms or stop the progression of the disease. Diet alone is simply not enough. Thank you for your time today.
Hello, my name is Natalie. I live in Tampa, Florida. I am mom to Anna and Jacob. Our journey with galactosemia started 2 days after Jacob was born. We happily took our newborn home from the hospital, but on day 3, noticed that he was not eating and appeared jaundiced. Called to the nurse's line, told us not to worry and just place him by a window to get some sunlight. But on day 4, this advice was clearly not working. So we rushed him to the ER as his condition began to rapidly decline. Typically, newborns have a bilirubin level of around 5. Newborns with jaundice may have 10 to 15. Jacob's bilirubin level was 44, which is incredibly dangerous and causes what is called kernicterus. This is when bilirubin crosses the blood-brain barrier and damages the brain and spinal cord. His situation was critical, and he was immediately taken to the nearest NICU. Doctors performed 2 blood transfusions to clean his blood of the excess toxin. He had 1 seizure during this process. The NICU docs then gave us the sobering news that our baby may not survive the night, and we waited through what is still the worst night of my life. And thus began a 25-year journey into the world of galactosemia. The term galactosemia was unfamiliar to us, and because the internet was brand new, it was actually the first word I ever Googled. From that point, we met specialty doctors, therapists, dietitians, lab techs, special educators, behavioral specialists, case managers, and others who, with our extended family, became the village that helped us navigate this new condition. Eventually, we created a new normal, and soon after, we welcomed baby number 2. She also had galactosemia, but we were old pros by then, so it was not as big a shock. I shouldered most of the daily burden of caring for 2 small children, while my husband, Joseph, served in the U.S. Air Force. Galactosemia affects everything for us. Just having a special diet means more consideration when you go to a restaurant, on vacation, to a birthday party, to a school function, or on a field trip. I always joke that my greatest fear is getting somewhere and having nothing for my kids to eat. Then there are the speech deficits, which cause errors of pronunciation, awkward pauses while speaking, odd substitutions of sounds or syllables. This then created barriers to communication, not only between the kids and me, but also with their friends and family who interacted with them. It created frustration, behavioral outbursts, and made it difficult to make friends. Being the first child and with no prior knowledge of galactosemia, Jacob has more physical effects than his sister. The high levels of galactose during the newborn period caused a domino effect of secondary issues. Jacob has cerebral palsy. This means damage to areas of the brain affecting motor movement, like walking, writing, or eating. Mobility is also a challenge. He's had PT, walkers, gait trainers, and DAFOs. Balance issues have caused falls, trips to the ER, and several sets of stitches. Even at age 25, Jacob suffers from pain in his hips, legs, and joints. At age 7, he was diagnosed with seizures. So managing his daily seizure medications takes time and effort. The seizures come in clusters, which keeps him out of school at times. At age 13, he was diagnosed with Crohn's disease. This is when the immune system overreacts and causes swelling of the intestine. He now has bi-monthly infusions of Remicade to keep the Crohn's in remission. Managing his health care and his educational services is a challenge, from attending IEP meetings, advocating for special equipment and services, and navigating medical insurance. Anna has a very different outcome because we were now familiar with the disease and its treatment. From day 1, she was placed on a dairy-free diet. However, because the diet is not a completely effective treatment, she still experiences effects. She had 11 years of speech therapy, which corrected sound substitutions and improved the ability for others to understand her speech. She also had years of occupational therapy to improve hand strength, finger coordination, used for writing, gripping, and feeding. At age 13, she began hormone replacement therapy, which continues indefinitely. Most female patients experience pre-ovarian insufficiency. This means it will be difficult, if not impossible, for Anna to have children in the future. Anna's success in school was hampered by speech delays, a diagnosis of ADD, anxiety, and difficulty in math. It was not an easy journey. So the fact that she graduated college this year means so much to our family. Recently, we learned that adhering to the diet is only part of the solution. It is now clear to researchers that this disease is progressive, and it will likely get worse as a patient ages. Personally, I have already seen a slight regression in Jacob's ability to walk, balance, and the time it takes for him to respond to a question. Jacob will never be able to live independently, have a job, or make life decisions on his own. While diagnosed earlier, Anna will still experience challenges with communication, anxiety, problem solving, social situations, and fertility. We are certainly concerned about how the progression of this disease may negatively impact their future. And we hope that by sharing our unique stories, we can both educate and advocate for future galactosemic patients and their families. Thank you.
My name is Maureen. I'm 50 years of age, and I live in Chalfont, Pennsylvania. I have lived with galactosemia for my entire life. Shortly after my birth in 1972, I began to show the classic hallmark signs of failure to thrive: jaundice, repeated vomiting, and weight loss. 7 days later, I was diagnosed as having classic galactosemia. Upon release from the hospital, my mom and dad were given a 32-page booklet entitled A Parent's Guide to a Galactose-Restricted Diet. They were instructed to follow this booklet, as I would need to be on a lactose-free, dairy-free diet for the rest of my life. At that time, the only treatment for galactosemia. I doubt my parents knew that many more challenges would lie ahead in the following years to come than just having me follow a dairy-free diet. It seemed like everything was working fine for me at the time, but I was getting older, and I wondered why I could not have certain foods. This was both a difficult and challenging time for me and my parents. Throughout my school days, I was always a low average student. Math was always my most difficult subject, and still is today. I struggle with making change, leaving tips at restaurants, percents, and telling time. Seeing signs in stores for a percentage off sale is hard for me to understand. Overall, it has been hard in many life circumstances because I struggle with any math that I need to process at the moment. It was not until I met other people living with galactosemia that I realized we all had comprehension similarities, including math. Although the diet may have isolated me from social events, my mom always made sure that I had a special treat to bring with me, not just enough for me, but enough for everyone to share. Modern advances in nutrition have allowed me to be able to have dairy-free ice cream and other foods I would not even have considered years ago. Within the last several years, I have also incorporated hard cheeses into my diet. Just as I was slow academically, I was also slow in developing physically. I would always describe myself as a late bloomer. While my friends were going through puberty and talking about it, I was not having any of these issues or normal signs, such as late development and still looking like I was in grade school physically as opposed to being in high school. It was not until I was 16 years old that I finally developed but continued the sense of isolation that having galactosemia made me feel. After going through puberty, I began to have unusual symptoms, such as hot flashes, mood swings, and night sweats. After about a year of experiencing these symptoms and having blood work, I was diagnosed at the age of 18 as having premature ovarian insufficiency, which is a direct result of galactosemia. This is something that I continue to struggle with today, more so than having a restricted diet. As a result of this diagnosis, I became very recluse. I wanted no part of dating or socializing like any other 18-year-old would be interested in. The impact of POI, secondary to having galactosemia, was very difficult. In my 20s, I just wanted to be like any other woman my age, socializing and having fun. However, I was depressed and had a difficult time making friends and meeting new people. There were many nights where I cried myself to sleep. At a church event in 1999, I met a man named Bill who showed interest in me and started spending time with him. I was very apprehensive about getting involved in a relationship, even though I was 26 years old. The fear of falling for someone only to have to tell him that I was infertile and taking a chance on losing this relationship weighed heavy on my mind. However, I finally got the nerve up to tell him. Bill is a pharmacist, and his response was priceless, advising me that I really needed to take my calcium because I was such a calcium slacker. I got that heavy weight off of my shoulders, and we celebrated our 21 years of marriage this past May. I was told long ago that having galactosemia was like looking through a glass window and watching others being a part of eating foods I could not have. I could see them through the window and through the glass, but could not break it or join them. This same is true for infertility. I can see moms and children through the glass, but cannot experience what it is truly like to be a mom. All my life, I longed to be on the other side of that window.
We really needed a minute to catch our breath from those stories. Wow, Maureen and everyone's stories were so powerful. And we are so honored to hear your courageous and very honest accounts of living with galactosemia, caring for a loved one, and in some cases experiencing loss with galactosemia.
Yes, some incredible stories, and they hit you very personally. Those sitting out of the audience, I'm sure you heard things in those stories that resounded with you. And I know for me and my son, Jacob, it was very emotional to hear that. Debbie?
Yeah. So now we're going to move into our second half and talk about your experiences and your perspectives on currently available treatments and your hopes on future treatments. We heard about them in our medical presentation by Dr. Judy about these treatments, and we want to understand the patient perspective. So what do these treatments actually mean to you? So we're going to welcome our second panel of patients and caregivers who will share their personal stories and their honest experiences with treatment and research, their preferences in research, and their hopes for the future. So we're going to start with Amber. Thank you. Amber, take it away.
My name is Amber Jones. I'm a middle school reading teacher in Oklahoma. My husband Aaron and I have two beautiful children. We were overjoyed when our son Holden was born with the most beautiful head full of dark hair and bright pink cheeks. The joy turned into fear when I received a call from the newborn screening lab relaying abnormal results that could indicate galactosemia. I called our pediatrician to express concerns regarding the lab result, but I was urged to continue breastfeeding, considering the high rate of false positives and the many benefits of breast milk. Unfortunately, this is common advice new parents receive from their pediatricians when results come back. Galactosemia is so rare that many of the physicians we encountered over the years had to research the disease or simply asked us to educate them during our appointment because they'd never encountered another patient with galactosemia before. 24 hours after we called the pediatrician with our concerns over the lab results, we couldn't wake Holden up, so we rushed to the hospital. Holden was life-flighted and intubated before being diagnosed with classic galactosemia at 9 days old at St. Francis Children's Hospital in Tulsa, Oklahoma. The breast milk I fed him caused his organs to begin shutting down and his body slipped into a coma. We spent many days and nights praying he would survive. Doctors were concerned about his chances of surviving and making a complete recovery. I had many questions about what life would be like for Holden living with galactosemia. And while they did not have the answers, they did assure me that his metabolic specialist at OU Children's Hospital would be able to answer my questions. When Holden recovered and was released from the ICU a few weeks later, we felt like we could take a deep breath for the first time since he was born. We began researching the diet and felt excited to be able to manage his disease. We decided we would transition our entire home to a galactosemia-compliant diet, and we felt ready to take on the new normal. We established Holden as a patient with his new PCP, metabolic specialist, geneticist, ophthalmologist, and neurologist. It did not take long for that immense joy to be shadowed by another dark cloud of grief. After meeting with the rare disease experts at Holden's genetics clinic, they explained to us that life wouldn't be easy for Holden. Since his body is constantly producing galactose, the same toxin that made him so sick, classic galactosemia is considered progressive. We insisted we'd travel anywhere in the country for the best treatment available. But unfortunately, our medical team explained to us that galactosemia is an ultra-rare disease and research is scarce. The only management option for galactosemia is a restricted diet, and this will not prevent disease progression. They advised us to begin early intervention at 3 months old to start various types of physical, speech, and occupational therapy to attempt to combat the disease progression. As therapists began coming to my home every week and noting concerns in his development, I felt helpless as I knew we were doing everything in our power to help him succeed. We were still falling short. He received an individualized education plan for his learning delays in preschool, and his occupational therapist noticed hand tremors, making it difficult for him to write in kindergarten. To this day, Holden continues to receive the same weekly therapies. Our first glimmer of hope came when Applied Therapeutics announced AT007, the first ever treatment for galactosemia. I reached out to Applied and asked to be placed on a waiting list for Holden to be considered for the trial. Sending that request was not an easy decision, as we knew the difficulties that would accompany a clinical trial. After considering the risk and benefit, it was clear that the chance to slow or stop the progression of his disease was something we had to run toward. We celebrated when we found out he would be participating, even though there was no guarantee that Holden would get the real drug instead of a placebo. We finally felt like we could do something to help him live a more independent life. We could help a future child have access to a treatment option at birth. We flew to Atlanta in July of 2021. Our first clinic day was Holden's 7th birthday, where he had to go through several assessments and many blood draws. While I can't prove that Holden is on the drug instead of placebo, it's clear that I can see his hand tremors are gone. He met his IEP goals for the first time since 2018. He learned to read, and his teachers and therapists have taken notice at how well he's doing as he masters grade-level educational standards. Galactosemia is a devastating disease. Families who receive this terrifying diagnosis should have an opportunity to access drug therapies before disease progression begins. Our community has everything to lose. What might seem like a short waiting period for a decision maker is more days of irreversible brain and organ damage for those diagnosed with classic galactosemia. Thank you for your time.
My name is Tiffany Platt, and my daughter Charlotte, who is currently age 9, has classic galactosemia. We found out on day 6 of her life through the newborn screen. At that point, she was already very ill and had been admitted to the neonatal intensive care unit. Thankfully, once we had a diagnosis and removed galactose from her diet, her symptoms improved, she finally began to gain weight, and we were able to take her home. However, we were devastated to learn that even though we could remove galactose from her diet, her body would produce its own galactose, which would get in her bloodstream and damage her nervous system. For Charlotte, the effects of this damage include cognitive impairment, motor and speech issues, fine motor delays, and a poor memory. She's only 9 years old, but her hormone levels are already indicating that she will likely experience primary ovarian insufficiency as well, which means it's unlikely that she'll ever have children of her own. One of the most frustrating parts of this disease is that there's no treatment available to prevent neurological problems. All we can do is make the symptoms less profound by treating them with therapy, which we've done aggressively starting at a very young age. She started physical therapy at 12 months, speech therapy at 18 months, and we enrolled her in a developmental preschool as soon as she was eligible for early intervention. Currently, Charlotte still receives speech therapy, occupational therapy, and special education. She makes progress, but she continues to fall further behind her peers every year, and the neurological damage continues to progress. This has taken a lot of time, coordination, and energy. And although I assume it's made her deficits less profound, it takes up all of her time after school, and it doesn't do anything to prevent possible tremors or other complications in the future. When we learned about a clinical trial for an experimental drug that lowers the levels of galactitol in the blood, we signed her up right away, hoping it was treatment that addresses the source of her neurological problems instead of the symptoms. She's already 9 years old, and we don't know if removing galactose from her blood and brain would be helpful or if the damage is already done and irreversible. However, we felt it was worth a shot as long as it was safe. And based on the safety data from the adult trial, we felt comfortable moving forward. The trial has not been easy on Charlotte. She's had to endure a lot of blood draws and testing. And when she's on the drug, she has even more dietary restrictions than normal because there's a whole list of foods that make the drug less effective. She also has to fast for 2 hours after she takes it, which means I usually wake her up really early in the morning so that she can take her medicine and still have time to eat breakfast before school. These hardships are very small compared to how much she struggles in life and school, and I would gladly make these sacrifices to alleviate her struggles and improve her quality of life. Even though our current trial experience has been difficult, I would sign Charlotte up for another clinical trial in the future as long as the treatment was safe and reasonably likely to improve her outcome. I personally would want to know beforehand how long the trial will last, especially how long the placebo arm will last, and also what the long-term studies would look like in terms of how often we would need to disrupt our lives to travel to the clinic. Our family is pretty desperate for a treatment, and given that clinical trials are a necessary part of development, we will participate in them as long as the hardships are reasonable. We have also participated in natural history studies, and we've encouraged everyone in our community to do the same. I hope that all the natural history data we've collected will reduce the need for a placebo arm, or at least shorten the amount of time the placebo needs to be studied. Lately, I've been reading about a lot of promising treatments on the horizon, and I'm very optimistic about the future. My hope, if an approved treatment becomes available, is that Charlotte can grow up and live a normal life. I hope that a treatment would enable her language and communication to improve so that she can sustain deeper, more meaningful relationships with her peers. I hope that over time she won't struggle so much in school. And I hope that one day, instead of spending all of her time after school on therapy, that she could participate in something she enjoys, like dancing or theater or sports. I also hope that if there's a treatment available, she won't go on to develop tremors as she gets older. And I hope that her ovarian function is saved and one day she can have children of her own. Charlotte deserves a shot at a normal life, and an approved treatment would give her that shot.
My name is Heather Sharp, and I live in Ottumwa, Iowa. My husband Martin and I are the parents of Peyton, who is 24, Garrett is 21, and Maxwell is 16. They all have classic galactosemia and have differing delays and deficits associated with this rare genetic disorder. I am mainly going to talk about the treatments and struggles that our middle son has experienced since infancy. Garrett was the happiest of babies. Cherub little cheeks. He started smiling at 6 weeks old, but unlike his sister, he was diagnosed through amniocentesis and was started on the restricted diet at birth, which he has stayed compliant throughout his life. He was meeting all his milestones till about 6 months of age. At that time, we noticed he started struggling to sit up, making good eye contact, and his babbling changed as well. Due to his older sister having been diagnosed with classic galactosemia, he had the advantage that he could receive early access monitoring. We started working with speech therapists, physical therapists, and play therapists. We would see growth in his skills, but never enough to have him at the average level for his age. Since the only treatment for galactosemia is following a restricted diet, Garrett is proof alone that we need more for our kids. The delays and deficits that have impacted his life compared to his siblings are drastic in comparison. His siblings do not have speech and language delays. They do not have learning disabilities, and they do not have seizures. These issues alone are life-altering without the other complications of classic galactosemia. When Garrett started preschool and on into grade school, his therapies became more intensive. My husband and I started noticing increased frustrations with his inability to communicate clearly, and he would start to act out and would become aggressive. After long conversations with his pediatrician, we started using behavior modification with him. This would assist him in his frustrations and also making it safe for us to handle these breakdowns. These techniques were taught to us by our pediatrician, and we adjusted what worked best for us and what benefited Garrett the most. It was very important for us to help him understand that everyone gets frustrated at times, and that it is not okay to take your anger out on anyone else. I truly believe this therapy has allowed Garrett to become a responsible adult who is accepted in his workplace and by his peers. Garrett was in 5th grade when he experienced his first seizure event. We were told that every child could have a seizure, and that if he started having any more, that we would need to have those looked into. Later that same year, he had a clustering event which led him to taking seizure medication to assist in controlling them. He still takes this medication today and could have to take it for the remainder of his life. We are very fortunate that the first medication that was prescribed to him has worked well when controlling his seizures. After a year from his first seizure event, he had an inpatient 5-day EKG. This was done due to him having some breakthrough seizures, and at the end of the testing, another medication was added to his regimen to assist in controlling his seizures. He also still takes this medication and will have to take it for the remainder of his life. Moving forward into junior high and high school, he still received speech therapy and special education services. Garrett was included in a general education classroom, but was pulled for extra assistance in math, reading, and speech. His speech services were received through the school and also through private speech therapy that we have obtained for him. He was taught skills to assist him in improving his speech and language skills and troubleshooting skills to help others understand what he was trying to say. Garrett has also been involved in research studies and trials. He does understand the results may not help him, but he feels that continued research is important for the future of galactosemic patients. The first study that he was involved in was a data collection study and was fairly easy to take part in. He also has participated in a medical drug trial, and that does involve a lot more time and dedication to do what is required of you. This extends to time off of work and being able to follow trial protocols. We feel both options are imperative for the future of galactosemia. Garrett graduated high school with his peers and was voted homecoming king his senior year. He was on the wrestling team and enjoyed the friendships he gained from being involved in many school activities. He now drives and has a full-time job at the high school that he attended, working in the kitchen and in the maintenance department. Galactosemia will forever impact Garrett's life. He will always have to work harder to complete a job that comes easier to most people. He will forever have to verify the food that he is eating is safe. His delays will continue to be something that he will have to work on a daily basis to continue to strive for a better life. That is why we feel it is so important for better treatments and a better understanding of classic galactosemia.
My name is Tara, and I live in Massapequa, New York with my family, which includes my husband, Joe, and our 3 children, Joey, Victoria, and Adriana. Our story begins 11 years ago with the birth of our son, Joey. He entered this world on February 8th, 2011, and I'll never forget that moment. Joey appeared as a normal newborn baby. Joe and I were first-time parents and just enjoying the overwhelming experiences that come along with a new baby. Unfortunately, it was short-lived, as within 24 hours, we received a life-changing phone call from a pediatric genetics doctor at Stony Brook Medical Center. She explained slowly that my son tested positive for galactosemia, and we needed to take him to the hospital immediately, while informing me to stop breastfeeding and formula feeding my son. Our sweet baby boy tested positive for a very rare metabolic disorder that untreated would lead to death. For the 3 days, I had been poisoning my newborn son with breast milk and formula. His body was slowly shutting down. When we arrived at the hospital, they immediately retested him to ensure positive results. As we sat in the neonatal intensive care unit, our minds channeled all the what-ifs. He was lethargic, wasn't eating, and slept most of the day. His liver was swollen, and he was jaundiced. His labs were off the charts. Joey underwent treatment by putting him under the Billy lights. He received multiple vitamin K shots and numerous blood plasma transfusions to decrease his labs. As the days passed, our son began to respond to a soy-based diet, and these treatments worked. He was slowly progressing, and Joey was released to come home on Valentine's Day. Joey has followed a restricted diet since diagnosis day, but is still affected by the neurological symptoms of this disease. As we introduced solids to Joey, we were also introduced to the first signs of galactosemia symptoms. Joey started with feeding issues that developed into speech delays, which led to behavioral and learning impairments. As Joey began his early academic years, he qualified for learning therapies, which included occupational therapy, physical therapy, speech therapy, and one-on-one teacher instruction in a general education class setting. Joey has a classified speech and language disability as a result of galactosemia. In his early academic years, the speech therapy focused on improving Joey's speech so he could be understood by others and able to express himself. A specialized form of speech therapy called Prompt was utilized on Joey for a few years, as this approach is where a speech and language pathologist places his or her hands on Joey's face to guide his jaws, lips, and tongues tongue to move correctly to form words. As a result of prompt, Joey began to articulate words correctly and speak in longer sentences. Joey was in a general education class setting for kindergarten and first grade and had one-on-one aides helping him stay the course of the general education curriculum. However, we didn't see Joey progress, and he fell behind his peers. In second grade, we made the decision to place Joey in a smaller special education setting with other children learning at his pace. This change was very beneficial, and we started to see Joey slowly progress. Joey continues today in this setting. Now in fifth grade, he receives speech therapy, occupational therapy, and individualized reading services numerous times a week. Speech therapy is an important component of Joey's education, as the language component of speech is where Joey needs the most help now. Speech therapy improves Joey's ability to understand and express thoughts, ideas, and feelings while increasing his ability to problem solve. Due to Joey's cognitive impairments, he utilizes visual aids in the classroom and at home, which includes charts, number lines, pictures, clue words, and color-coded text. Even in this setting, Joey has significant academic delays, and progressions towards his goal is minimal. Joey is limited in his communication skills, ability to read, and basic math skills. Joey recently got approved for assistive technology and will be able to use those tools for assistance in school and in everyday life in hopes that he will be able to use support tools needed to live his life independently when the time comes. Some of the tools Joey uses are text-to-speech, which helps Joey read, Draft Builder, which is a writing tool that utilizes a graphic organizer to help Joey visualize what he wants to say, and it inserts his information into the appropriate place without having Joey conceptualize the whole process. Ginger, which provides Joey word predictions and sentences, rephrasing tools to help him construct a sentence properly. Math simulations help Joey better understand a particular type of problem by watching animated simulations of how a problem would work. And then he would be able to see how the results play out in that situation by working through it. These delays impact Joey's daily life, but he remains true to himself. He works through these challenges and enjoys being social with his friends. Joey eats a restricted diet, dairy-free. His liver is functioning normally, and his galactose levels are in the acceptable range. However, the neurological impairments of this disease become more evident year over year. I want Joey to participate in clinical trials to help researchers discover the best way to treat galactosemia. Joey wants to help others, and we all want him to receive possibly the newest treatment and to have the care and attention from the trial doctors and staff. We're hopeful for future treatments to limit the symptoms of the disease, but worry that those treatments will be presented too late in Joey's life to reverse the neurological damage already done, and that will continue to be done.
Hello, my name is Amy Morrow, and I live in Clarksville, Tennessee. My son Adrian is 6 years old and suffers from classic galactosemia. He is in first grade this year. There was much debate over whether or not he should repeat kindergarten because of the many learning delays that are associated with classic galactosemia. Along with learning delays, he deals with speech delays, fine motor issues, and behavioral problems. He is quickly falling behind his peers. When Adrian is asked a question, he often takes a while to form his thoughts, and many times he is passed by because people think he doesn't have anything to say. So he doesn't get to say what he's thinking, even though he's been asked a question. Behavior is also difficult for Adrian, particularly when things do not go according to his plan. He truly doesn't cope well when things go wrong. My husband and I are concerned that he will not be able to be an independent adult if this disease continues to progress. This is why, when he was 3 years old, we decided to look into research and learn about any investigational treatment. Adrian has been in speech therapy and occupational therapy since he was 18 months old. These interventions have been helpful, but they are a very slow process. Because galactosemia is such a rare disease, most therapists have not even heard of it and don't always know the best methods for kids with galactosemia. This makes it difficult to find the ideal therapist. Currently, we are in a new city, and it's already proving to be complicated to find a therapist who are best suited for Adrian's needs. When I heard about the current drug trial, I was skeptical because I was very concerned about safety. I am grateful for the adult trial that came before the pediatric drug trial, as it showed the efficacy and the safety of the drug. I was glad to hear that this drug is non-invasive and it's only taken once a day orally. This sounds very tolerable for my child. Adrian has been in the trial for over a year now. The most difficult thing about the trial for him is the amount of blood draws that happen. He has developed much anxiety over the blood draw. We traveled to a clinic at the University of Michigan for this trial. He did not like to hear that we are going to Michigan because he knows that means he will have a blood draw. He is fortunate that once he has an IV in his arm, he does really well. However, the anxiety that leads up to the blood draw is pretty extensive. Along with the visits to the clinic, the trial includes multiple home visits from a home health nurse. There were several nurses that were amazing and did really well with Adrian. However, that was not always the case. Adrian had several nurses who struggled more with him, and the experience wasn't always ideal. There is no way to prove whether or not Adrian is on the placebo or the real drug. It is difficult to see my child have so much anxiety over blood draws and a clinic visit, especially when we don't know if he benefits from the drug. I believe that placebo is such an important part of this trial. However, because we are dealing with children, the length of time that the child is on the placebo should be taken into consideration. The kids are suffering a great deal from this trial, and all of them deserve to be on the actual drug in a timely manner. Our family chooses to continue in this trial because we have great hope for Adrian and for other patients like him. The data that we have seen so far for this trial is really exciting. We look forward to a treatment that will help Adrian be a successful and independent adult. We hope for a treatment that will be a brighter future for the galactosemia. Thank you.
FDA regulators, as they consider your experiences when they do their work in decision-making around current and future treatments for galactosemia. Our panelists did a wonderful job starting to describe the community's experience around existing treatments and how these therapies have really changed their lives and the lives of their loved ones living with galactosemia. And we know there's no perfect drug or treatment, and there are always ways to improve upon treatments.
So now, Scott and I are very pleased to turn it over to Brittany Cudzillo, the Galactosemia Foundation's Vice President, to give some closing remarks before Scott wraps us up. Brittany.
Hey, everyone. Thank you to Debbie and Scott for moderating such a wonderful discussion that we've had over the last 4 hours. It's been incredible to be a part of this. Thank you to the FDA for valuing our voices in this community. We're so glad to have been able to do this with you. Thank you to the panelists for your vulnerability and your courage and being willing to share your stories, and to the community members who have aided in discussion and polling. It's been great to hear everyone. I have the distinguished honor of trying to take all 4 hours we've been together and summarizing that in 10 to 15 minutes. The meeting was opened by Peter Saltonstall, the president and CEO of NORD, followed by a welcome by Nicole Casal, our president of the Galactosemia Foundation. A clinical overview was presented by Judith Fridovich-Keil, a PhD professor in the Department of Human Genetics at Emory University School of Medicine. She shared that galactosemia is a rare disease caused by an inborn error of metabolism genetically passed down through 2 mutated autosomal recessive genes, causing a profound deficiency of the GALT gene responsible for breaking down the sugar galactose. Without the GALT gene, galactose is converted into the chemical biomarkers of galactose-1-phosphate, galactitol, and galactonate. The incidence of galactosemia in the United States is about 1 in 50,000 births, being about 80 babies a year, about 3,000 people in the United States living with it currently, with a slightly higher incidence in the white ethnic group and a much higher incidence in children due to the newborn screen saving infant lives. In infancy, galactosemia becomes a metabolic crisis, but once the diagnosis is made and safe formula is given to the infant, you typically see them heal from those initial complications. This, however, does not stop the disorder from leading to long-term complications. The long-term outcomes for patients with galactosemia are variable, as we've talked about today. However, we're able to deduct with certainty that the current treatment plan of dietary restrictions saves an infant's life in the short term, but does not prevent lifelong complications from the disorder. Many children and adults with galactosemia suffer from cognitive delays, speech and language difficulties, neurological problems, socio-emotional difficulties, low bone mineral density, and pre-ovarian insufficiency in female patients. Dr. Judy's medical presentation was followed with a presentation from Dr. Sheila Farrah, who is a pediatrician and a reviewer in the Division of Rare Diseases and Medical Genetics at the U.S. Food and Drug Administration. Dr. Farrah shared that PFDD meetings are valuable to the FDA to learn from the experts, people living with galactosemia and their care partners to help facilitate treatment development, design clinical trials, and review new drugs for galactosemia. We then started the patient experience of our time together with panel 1 talking about health effects and daily impacts of galactosemia. DJ shared his hope for a medical treatment of galactosemia and the apraxia it has caused in his life. Jillian shared the hardship her daughter Penelope has had with galactosemia, including infant metabolic crisis, gut issues from E. coli sepsis in infancy, frequent seizures, sensory processing disorder, significant hand tremors, and constant regressions of speech and motor skills. She also highlighted the frustration and coordination of care and the danger of prescription drug use with unsafe ingredients. Elaine shared her story of infant loss with 2 of her children and the effects galactosemia has had on her son Jerry, who was saved in infancy after being in a coma but has suffered long-term complications such as mentally disabled, bullied, seizures, having a hard time verbalizing his needs and wants, and the struggle with any kind of change. Jerry has not been able to live independently and currently lives with his sister, who helps coordinate his care and handles his finances. Cassidy shared that her daughter Alina's diagnosis in infancy. Since then, she has struggled with slow processing speed that causes her to struggle socially, physically, and educationally. Alina lives frustrated by her constant need to catch up and feels left behind by her peers. She also shared that there have been financial struggles to keep up with doctor's visits, therapies, and tutors. Cassidy highlighted how she feels ill-equipped to care for her daughter and they are desperate for more treatment. Natalie was next, and she is a mother of 2 children with classic galactosemia. She shared how her son, Jacob, has lived with speech struggles, cerebral palsy, behavioral delays, and seizures since his near-death experience as an infant. Her daughter, Anna, who was placed on a galactosemia-safe diet from birth, has lived with speech delays, ADD, learning delays in math, and has been on hormone replacement therapy due to pre-ovarian insufficiency. She also shared the hardship of dietary restriction that can be caused in many settings outside the home, being afraid there will be nothing safe to eat. Maureen was last in this panel. She shared her struggles, as an individual with galactosemia, socially and physically, specifically with dietary restriction, hardships in learning at school, lifelong math challenges, and her struggle with pre-ovarian insufficiency, which has led to the inability to have biological children. We had a robust discussion on panel 1 when we opened up to everyone here. And we heard from a lot of community members about the hardship in controlling seizures, learning disabilities that seem to be caused by slow processing speed and memory problems. Pre-ovarian insufficiency was brought up, and the heartache of not being able to have biological children. The stress of insurance coverage for medications that control symptoms such as anxiety and seizures, social anxiety and the struggle to navigate meeting new people and keeping up with conversation among peers, muscle weakness that affects hand-eye coordination, dental concerns with weak enamel, and how all of this continues into adulthood, making living independently a challenge or not an option at all. In our afternoon session, we've talked about perspectives on galactosemia treatments. Amber shared her son's management of galactosemia includes his team of doctors, such as the metabolic specialist, an ophthalmologist, and neuropsychologist. He has an individualized education plan for his tremors and learning delays and has been enrolled in physical, speech, and occupational therapy. Holden has been participating in a clinical trial for galactosemia and has seen improvement in his learning delays and tremors since starting that trial. Tiffany shared her daughter receives speech therapy for her language delays, occupational therapy for her fine motor skill delays, and special education for her learning struggles, yet she still continues to fall behind her peers with her neurological damage continuing to progress. Charlotte has been participating in a clinical trial. They have been part of a natural history study, and Tiffany expressed her desire to see a treatment, even if it means being in a hard clinical trial, as long as that is a safe treatment. Heather has 3 children with classic galactosemia and focused on sharing about her son Garrett, who was diagnosed via amniocentesis and has always been on a safe diet. From early in life, he has been in speech and physical therapy, and as he grew older, he needed more intense speech and behavioral therapy along with special education services. Garrett started having seizures in 3rd grade and will be on medication to control them for the remainder of his life. Garrett has been in a natural history study and a clinical trial. Tara and Joey then shared that although Joey has been on a safe diet since day 3 of his life, he has suffered many neurological complications from galactosemia and has been in speech, physical, occupational therapy, and is currently in a one-on-one education setting. He is impacted daily by galactosemia, and they are committed to long-term studies to change the future of galactosemia for Joey and for all future patients of this rare disease. Lastly, Amy shared her son, who is currently in 1st grade, has struggled with learning, processing speed, and behavioral issues that has caused their family to seek out investigational treatment options. He has been in speech and occupational therapy, with growth being slow and frustrating. Amy has concerns about her son living independently in the future and is committed to studies that could bring about more treatment options. Amy has expressed concerns about the length of time a trial must stay in the placebo arm, wanting as many people to have access to experimental treatments as possible. Key points from our discussion as a whole community. We saw that in our discussion, there was a lot of talk about types of medication and treatment that we've been using in our daily life for the treatment of galactosemia. We heard about how anxiety and depression medicines are used, but don't seem to completely help the symptoms and also seem to cause their own set of issues. Many take sleep supplements, probiotics, and Miralax, which are used into adulthood to help with severe life-altering constipation, which we've heard a lot about. And many take supplements in vitamin D and calcium for bone health. Many of our community members involved in this meeting have highlighted the use of speech, feeding, occupational, and motor therapies to help alleviate some of the severe symptoms that galactosemia causes, such as apraxia, speech, and motor skills. The financial hardships have been talked about, including paying for pharmaceuticals, therapies, and tutoring, and how burdensome that can be for families. The underlying theme during this discussion really was focused around how hard those with galactosemia work to learn, communicate, and understand their peers without seeing very many gains, all the while feeling exhausted and overwhelmed. Pharmaceuticals and therapies have seemed to help with those struggles, but they're not enough. Most families who spoke talked about early intervention, yet are still struggling to help their children learn and thrive. Most families are exhausted, and quality of life is affected when therapy is so frequent that there is no time or energy for anything else. Many also expressed feeling like there is no endpoint, and during polling, it was shown that putting all the treatments available together, they still only somewhat to very little feel like they are treating the symptoms of galactosemia. So overall, we have heard about the tremendous unmet need in galactosemia in our entire community. Each of the major symptoms I've summarized here have incredible quality of life impacts. Treatments are mostly targeted towards symptoms, and there are no FDA-approved treatments for galactosemia. Treatments can be helpful, but most do not really treat the underlying cause or stop the progression of galactosemia. Research and development in this area is desperately needed. And now to close the meeting, back to you, Scott Saylor, our meeting co-moderator.
Thank you, Brittany. So we are at a close for this meeting. We've tackled some heavy topics. Galactosemia is a brutal disease, but our families are strong and courageous. We're grateful to hear them share their stories, their diverse experiences so honestly. From those who have had severe impact to those who were diagnosed more recently, and maybe we possess some of the tools now to fight back. What they all share in common is an incredible resilience and a desire to live their best lives. For those living with the disease and for future generations, we know this meeting will help bring better treatments, better options, and more hope to change every galactosemic's life, including their families. It is not enough to live with the disease. We want to thrive and have the opportunity to be part of society, to live independently, to be in relationships, to keep up in school, to learn, to grow, to have families. What you've shared today and what you can continue to share and comment after this meeting will work to ensure that voices of the people living with galactosemia in this disease will be heard by and considered by those who play a role in galactosemic drug development and research. The proceedings of this meeting will facilitate the development and regulation of new therapies. Those in the FDA listening now and those that will listen in the future will get a better understanding of what you lived through and what you hope for in research and treatments in the future. What you say helps them think about what matters to you and how to balance risk and benefit when reviewing a new drug. A past FDA PFDD we heard a high-level staff member share, continue to speak up, and the FDA will continue to listen. And we must continue to speak up. It's been an incredible afternoon with our community. It was an honor to be a co-moderator for this historic meeting of the galactosemia community and the U.S. Food and Drug Administration. I'd like to thank our audience, the FDA staff, researchers, clinicians, patient advocates, and everyone involved in advancing research and hope for galactosemic patients and families today and to future generations. I'd like to recognize the team at the Galactosemia Foundation who worked for the last year to put this together. We're grateful for our courageous panelists and all of you who tuned in live, who shared so freely, who spoke up at this meeting. Most of all, I'm grateful for this community and their spirit and their heart. That is why we continue to fight. Please continue to share through the web link on this PFDD page. Thank you, be well, and goodbye.